RPA is classified PG. It contains medical procedures. The Nine Network recommends parental guidance for young viewers.
Und der Daktari?
Tonight on RPA.
High five. Oh.
Sylvia, the little girl from Africa,
She'd like to walk.
She'd like to walk.
is opening Aussie hearts
Hello there, you're back. You had a good day.
Yes.
while doctors work out if they can make her dream come true.
It's quite a complex problem.
A rare disease,
1 in 400,000 women.
and 26-year-old Erin is feeling its fury.
We were just sort of thinking, you know, I've just been given a death sentence.
So that spine is being crushed,
And that's where the nerves that go to make your legs walk.
but rescuing him uncovers a shocking truth.
To continue doing the operation now would be a mistake.
How long do you think my father has to live?
And remember Renee?
Did she just tell me I have a brain tumour? Surely not.
1 year on, we discover a very different woman.
I don't look like the person I used to be, and I'm certainly not emotionally the same person.
G'day.
Hi.
How are you?
Good, thanks.
G'day. Take a seat. Now, we're seeing you for this problem you've got in your spine. How long have you known you've had cancer for?
18 years.
And where did it first start?
In my kidney, left kidney.
And the kidney came out, and then you had a big deposit of kidney cancer that had spread via the bloodstream and landed in your spine.
That's right.
This deposit in your spine suggests that it's beginning to get a little bit away from everybody, and that giving you more radiotherapy there is not going to cure you of this. Giving you chemotherapy is not going to deal with it. So that just leaves you with the third main arm of the treatment options, and that's surgery, and that's what you're here for.
G'day, this is Erin. We've just picked her up from Air Ambulance. She's been flown down from Port Macquarie for treatment for her Lamb's disease.
Yep.
It's a fairly rare condition. Apparently the flight sister was telling me only 2 or 3 in a million.
Yeah, it's lymphangioliomyomatosis.
Yeah. Currently she's in significant pain upon any sort of movement to the left side, going down the retrosternal area as well. Being good en route, but upon any movement, upon rolling over to get the board under, she will yell and scream, but that's the norm for her. So we've been told. So.
All right, on 3, 2, 3.
Sorry. That's it. Okay, no more. Okay. Breathe deep.
Okay,
1, 2, 3. Thank you very much. Lovely.
When we look at the MRI scan of your lumbar spine, the bone is black, you go up the spine, but this vertebra here, which is the L2 vertebra, and to a lesser extent a little bit of the L3 vertebra, the back of the vertebra and almost the whole of this vertebra are white.
Right.
And that's where the cancer is growing inside the bone.
Right.
If we don't do anything about it, the cancer at the front of the vertebra will gradually grow back further and further and squash your spinal cord. And that's where the nerves that go to make your legs work, the ones that go to make your bowels and bladder work. And so we would like that not to happen, obviously. So to deal with that, we have to take out the third lumbar vertebra and the second lumbar vertebra. That's all right, we can do that. The problem is, of course, you need to be able to walk around. So we have to put something back in there to hold you upright.
Right.
Hi, Erin. How are you?
Not bad, a bit of pain.
How's the pain?
Yeah, it's sort of when I take a breath, it's still really sore.
Are these your parents?
Yep.
Hi.
It's my dad.
Cameron, Cody. Hi.
That's my wife, Helen.
Hi. So, Erin, I had a look at your CT scan of your lungs, and it does confirm the diagnosis of LAM. It's quite a rare disease. About 1 in 400,000 women develop, for some reason, a disorder in the smooth muscle cells, which is a type of cell in the body. Basically, LAM usually affects you in 1 of 3 different ways, and unfortunately, you have all of them. So, firstly and most commonly, it can cause little holes in the lungs and cause some problems with the breathing. So we'll have to keep a very close eye on that. The other way which it can affect you is by causing a leakage of the lymph.
They put the chest drain in, expecting just to drain some fluid, and then it was like over 5 or 6 litres of chyle came out instead. So that's when they were able to diagnose me.
Exactly.
Yeah.
I guess the third way in which it can affect you is by causing tumours, and I know that's what your current problem is.
Yeah.
Oh, so just show me where the pain is.
All over my belly.
Yeah.
And it goes around to my back as well.
So LAM can sometimes cause usually benign little tumours in and around the kidneys, which often don't need any treatment at all, but obviously in your case it's causing you so much pain that we need to try and fix it and get rid of it.
What we need to do is involve quite a few other of my colleagues in helping you.
Right.
The particular ones we want are the radiologists in the X-ray department, and they are extremely clever. They put a little tube into your groin, up your main artery, your aorta, and find the little blood vessels that supply those two vertebrae with their blood supply.
Right.
They then block off the arteries that are supplying those two vertebral bodies with their blood supply.
Right.
And that makes things a lot easier for me, that when I cut into the vertebra, they don't bleed back at me.
Right.
That's called an embolization.
Oh, right, okay.
They would embolize that the day before, and then we take you to the operating theatre. It's a major operation, and after the operation we go from being very nice to being nasty, and we make you get up and get walking because that's good for you.
A bit pain, obviously.
I won't be able to feel your pain at all.
So Erin, that's a lot of information. How are you feeling about it now?
When I first heard about it, I was just shocked. I was sitting with my 2 friends, and the doctor handed us like a piece of paper, and this is what I had. And we went on and researched it, and it just tells you how it's a terminal illness and, you know, the lifespan and the death rate, and it was really high. So we were just sort of thinking, you know, I've just been given a death sentence. But now I feel better about it because I know that, you know, there's possible medications that you can take to help slow down the cysts, and, you know, it's
We'll
not
keep
as
a
bad
really
as it-
close eye on you as well. Yeah.
So no, it's okay. I feel like a few weeks ago I thought I was going to die, and now I feel like, do you know what I mean? I might have a bit more time under my sleeve.
There's some hope.
Yeah.
Good.
Yeah.
Yeah. I think right now the priority really is to try and fix the pain and the tumour. But after that, certainly we will need to think about the fluid and then keep a close eye on the little cysts.
Yeah.
Yeah.
What you need to know is what's the alternative. Well,
That isn't much, I think.
well, that's right. You've used up lots of the other possible opportunities over the last however many years.
Yeah.
You can't keep giving more and more radiotherapy to the same spot. Eventually, everything will just break down. So there's a limit to how much radiotherapy you can have. There may be some drugs that Professor Tattersall will want you to have, but the first and foremost thing is to keep you walking by taking that out. When we look at the MRI scan, we can see where the disease is. We think we can get it all. We may not, but all we can do is remove what we can see and what is removable.
Hello there. Hello, Mark Horsley. Hello all. Pleased to meet you.
Hello, Sanjay Gupta, how do you do?
Hello. Good morning, Mark Horsley. Hello there. Pleased to meet you.
Hi, Sylvia. How are you?
Well, we're both orthopaedic surgeons, Sanjeev and I. So we gather Sylvia here has some problems that we may be able to help with in the foot. Does Sylvia complain of pain as such?
No, she has no pain whatsoever.
Okay. And how does she get about? How does she walk?
She can put some pressure on the right stump.
Can we see Sylvia hop up and...
Yeah, sure. Sylvia, daktari anataka kukuona ukitembea kidogo.
I love her hair.
Thank you. Haya, tembea mpaka hapo, malilisa yako na urudi. Enda mpaka malilisa yuko.
Okay.
Great. Okay.
Hi, good afternoon. Richard Waugh. So bad, is it?
Yes.
This is my assistant, Jason Temilovsky.
Hi, Jason.
First of all, we've got Vincent to put you asleep because it's a fairly long procedure. You get a bit uncomfortable.
Yeah.
We put a little catheter, a little tube through the artery in your groin.
Yeah.
Take some X-rays of the circulation to the vertebral body, and put little bits of particles and maybe some little platinum coils to take all the blood flow away from the cancer. So the Dr. Stelly will have a more successful procedure without losing a lot of blood.
Right.
Can Sylvia feel me touch her down here?
Unaweza kumsikia kikuguza hivyo?
Yeah. It's quite a complex problem. When you have a burn, the skin shortens up and tightens up. And when that happens, you can see here, it just pulls everything out of position. When a toe has been out of position for a long time, sometimes after that surgery, we need to even put a little pin down a toe, or even in the foot here, to hold in a correct position whilst it all heals up again. And with this leg, what may need to be done here is to make this into a what we call a proper stump, so that a prosthesis can be fitted, and we'd need to have an X-ray of that as well and just work out what needs to be done there.
Thank you.
Sylvia? Bye-bye.
She likes giving high fives.
High five. Oh.
So Jason, you can see all the tumour vascularity here, all this black staining.
Yep.
And I don't see any abnormal blood supply to the spine, the spinal cord. We should just float in some particles and just take out that blood supply, and they should block off those vessels very quickly. So I just very slowly put it in. You can see it just going down the vessel. So these particles have blocked all those vessels, tumour vessels there, and now you can see there's virtually no flow whatsoever into the lumbar artery, and particularly no flow into the tumour vessels. Good?
That's a good result.
It's a great result. There's no filling, whereas before we had all that black tumour vessels there. The main vessel is just stationary, and there's no virtually any filling whatsoever of the tumour vessels.
Do you want to lay down, Sylvia, for me? Just lay down.
Lala chini, lala. Lalia chini.
Yep.
Angalia,
Just
lala
like-
ukiangalia juu.
Excellent, very good. And I'll just pop this on, okay? And we'll just get the foot on a plate. What I'll need you to do, just put your hand here and hold the leg.
Nitakushika
Just a
mguu
little.
hapa.
That's excellent,
Okay,
great.
vizuri.
Very good. Is she always this quiet?
No, God, no. She's an absolute chatterbox, this one.
Okay. Now I'll just
Utasikia uchungu sana.
good. Take one picture like that, okay? That's very good. Excellent.
How you going? All right. A little bit silly with that thing on your head and that blue hat, but you'll be right. Do you know what we're going to do today?
I think I do, yeah.
All right, we're going to start on the back. We're going to put the rods in the back to stabilise your spine.
Right.
But we have to stabilise you from behind first of all.
Right.
Otherwise, the top won't be connected to the bottom, will it?
Right, okay.
Okay. Any other questions?
That's all on your hands now from now on.
So we'll get you out as quick as we can, back up on the ward.
Okay.
But you'll be spending a bit of time in bed recovering.
Okay.
All right?
Okay, thank you.
We'll see you in a second. Alfred will be with you in a moment.
All right.
Bye-bye.
Bye. Okay, so this is an X-ray of Sylvia's right leg, and you can see that down here, this is where she's had partial amputation, and interestingly, she still has part of her foot still attached, but it's actually pointing in the other direction. Unfortunately, what you can also see here is that she doesn't really have much tissue at the end of the bone, and so Sylvia's actually walking right on the end of the bone there. which is probably why she's having so much irritation from the skin at the base. And this is an x-ray of her left foot. Here the bones are pointing down slightly, but the main thing that we can see is that the entire foot's just rotated sidewards and the big toe's pointing inwards. The problem also is that because it's been like that for such a long period of time, the joints themselves look slightly abnormal. Because of the complexity of the surgery, we do probably need to get the advice of a paediatric orthopaedic surgeon. And I think going forward, there is a potential that Sylvia will require further surgeries as she's growing. And so I do think it's important that we get the paediatric orthopaedic surgeons involved in this. Overall, everything that we've seen I think is treatable, but I think it's going to require a variety of people to be involved to try and get the best possible result for her.
Is there a chance that the tumour could be cancerous?
There's always the chance that any lump in your body can be cancerous, but cancer tends to look ugly, and yours is a nice, smooth, sausage-shaped mass, which makes it more unlikely to be cancer.
Okay.
But the important thing is it's causing you pain, and so we've got to get rid of your pain by taking this lump out. LAM, as you've experienced, is an extremely difficult diagnosis to make, and there's probably a lot of people who remain misdiagnosed. Because they present in a vague sort of fashion, and it's a very rare sort of constellation of symptoms and signs. In your situation, because of the way the thing in the tummy looks, we'd actually prefer to cut it out.
Yeah.
Hi, how are you? That's good. Have you had a CT scan before?
No.
No, you haven't. So when we take you inside and have a scan, you just have to hold nice and still and only take us a few minutes. Okay, it's like having pictures with Dad. Okay? And make sure you smile.
Picha, unakaa umenya, usitingike sawa. Alafu una smile, si ndio?
So what we'll do is, we'll get her to lay flat on her back and we'll pop her head here, feet at the end. Okay?
Aya.
Good girl. Okay? And we'll try and look after your pretty dress.
Oh, you better, because it's a present from the whole community.
Ah, well, I'll be extra sure. Okay, so tell her, must keep her legs very, very, very still. Do not move them for the next 2 minutes.
Sylvia, saizi tunaenda kupiga ile picha kubwa. Usitingize mguu yako hata kidogo. Good girls.
Excellent. Let's go. Well done. So now we're going to scan and we'll get nice, perfect blood flow in both legs, and the surgeons have a really good look at the vascular anatomy of her. She's going to throw up. Okay, run in. She's going to throw up. Are you okay? What's the matter?
Oh, she just felt it really cold.
Oh, okay.
Ni sawa, iko
Okay,
hivyo.
let's check the pictures.
Yes.
Let's make sure. Give me a minute.
The lump in your tummy is pretty impressive because it goes from up underneath your diaphragm, it goes all the way down into the pelvis. The important thing is the lump itself is neither here nor there, but the things that it's near and attached to, the left kidney and the pancreas, and possibly the adrenal gland. The good thing about the pancreas is it's just the tail of the pancreas, but one of the things about the tail of the pancreas is it's very, very close to the spleen, and your spleen might need to be removed. Whilst you'd like to hang on to your kidneys, if we have to take it out, well, then so be it, but you've got a right one. You don't have to alter the way you live. You can actually have a normal diet and and drink normally, water or alcohol. And the adrenal gland, once again, lovely to hang on to it, but you've got two, and you only really need one. All the things in your guts and things are all pushed forwards by it. So we lift those all to the side or towards the midline, and then we basically take out this large tumour, taking whichever things it's attached to.
Okay.
So you can also see the little arteries going down into her foot and ankle.
Yeah.
And this is a very successful study. And the surgeons will be very happy with this, and it will help them look at what they need to do for Sylvia.
Sasa kina Dr. Rom tutafurahia sana.
Right. I wish you all the best. Hope all goes well. My pleasure.
Thank you.
No worries. Okay, let's do it.
Sylvia, tumemaliza. So tunaweza kwenda zetu nyumbani.
Thanks.
My pleasure. Thank you.
Thank you so much for that.
No worries. Are you still feeling cold?
Bado unasikia baridi? No.
Good.
Okay. Did you eat or drink anything today?
No.
All right. Are you allergic to anything?
No.
Good. What sort of operation are you going to have?
It's a removal of a tumour.
Yes, in behind there, isn't it? What they call retroperitoneal. In right in behind everything. Good. Now, you'll be going to intensive care afterwards. I think that's about it, all right? So have to say bye-bye for a little while?
Yep.
Okay. All right, sweetheart, we'll take you.
Yeah.
See you later.
Okay. Don't have to do it again.
Too many goodbyes. Right. You'll be right.
Bye.
Hello there, you're back. Have you had a good day? Yes, have you?
How you got on? How's that knee? You come to me now. Oh. Pass around. Let's see. Where is it?
What did they do?
I guess we wanted to have Sylvia and Francis come and stay because it was an opportunity for us to give something back.
And it's been really nice for the kids in that way as well, for them to actually be more appreciative of what they've got when they actually have to stop and think about the fact that Francis and Sylvia haven't got running water at home and haven't got electricity in their home. It's been a real eye-opener to all of us.
Appreciating what we tend to take for granted every day.
1 step, 2 steps.
She's got this personality that just fills the room and just draws people to her.
8, 9, 10.
We just can't wait now to see her the other side of the operation, and just be wonderful to actually see her walking.
Tisa, come
Well done.
Morning, Erin. You've got to surgery. Yeah, I understand over the weekend you had a chest drain put in. Did Tam organise that?
Yeah. Just because the X-ray showed my lungs were full of fluid, so.
So the fluid had come back.
Yeah.
Okay, and as a result of that chest tube in, you felt a lot better?
Yeah, it drained 2 litres.
2 litres.
Yeah.
We'll do everything possible to preserve your kidney.
Okay.
And the other things we talked about, well, it's a matter of whether the tail of the pancreas is involved, the adrenal gland, and I'll give your family a call as soon as we're finished.
Okay, great.
Okay?
Thank you.
So we're just opening up the abdomen to hopefully remove this large lump, which is related to her LAM. Carlo, what do you know about lymphangioliomyomatosis?
It's a very rare condition. It's mainly female under 30 years old.
Did you look that up or did you know that sort of stuff?
I remember something from the medical school.
Is that right?
Really?
I'd never heard of it. The tumour at first sight appears to be very soft, so we'll have to try and keep that intact. The tumour is roughly about 20-something centimetres long, disappearing up next to the spleen, and we're able to mobilise it
at least away from the bowel so far. I haven't gone behind it to see what's happening with respect to the kidney.
Hello, welcome back. Welcome back. Sylvia, how have you been since I last saw you? Been pretty good? You look pretty good. Oh, you put on a little bit of weight, haven't you? That's good. Good girl. Since our last consultation, we've had a look at the x-rays that we managed to take of Sylvia. With the operation on Tuesday, the goal will be to release this and bring this forward so that this heel pad becomes the weight-bearing surface rather than the end of the bone, which you can see coming through here. It means that as she grows, her leg will grow proportionally with her other leg as well, so that discrepancy won't increase as she gets older and taller. On the left-hand side, our goal will be to release this contracture and allow the foot to move into a more natural position that Sylvia is then able to use that weight-bearing sole. We're going to end up doing this procedure out at Westmead Children's Hospital next Tuesday.
Fantastic.
It will be good seeing my daughter walking herself without me carrying her every time.
Yes.
Yeah, because I've carried her for a long time. I'm happy.
I'm not sure what's going on at the moment, but the tumour would appear to be full of blood, which could easily explain why she's been having some pain. And surrounding the ureter and going up into the kidney. The kidney itself looks all right. So what we're just doing at the moment is trying to find the ureter, which seems to be surrounded by this tumour. The ureter is the main tube that takes urine from the kidney, where it's formed, down to the bladder. I think we'll get rid of this major part of the tumour. It's full of blood, very clearly been a hemorrhage into it, even though the scan didn't look a lot different. And as I said, there's some solid components, as you can see, that sort of, not, I wouldn't call it hard, but much firmer than the cystic component. And that's now deflated, but inflated. It was about 20 centimetres long.
So you're going to find Lisa?
Yeah?
Yeah, Sylvia, you're going to give Lisa a big hug. Here we are. It's a big day.
They're going to mend your leg. Yeah. Today's big, exciting day, isn't it? Yeah. Be exciting. Yeah.
And then when you have your operation, when you wake up, who's going to be there when you wake up? Lisa?
Lisa.
And Daddy?
Lisa and Daddy.
Yeah,
You
Daddy.
are
a monkey.
Lisa and Daddy.
Yeah?
So we will both
They'll be there for you.
You'll be there?
Yes.
Huh? Right, you. Hey?
Round around the garden like a teddy bear. One step, two steps.
Too slow.
So everything has gone really as well as we could have expected, and Erin has kept her left kidney. So we've preserved all the structures we really wanted to preserve. It was next to but not involving the spleen. It was next to but not involving the tail of the pancreas. And I suspect that it has risen from the adrenal gland.
Sorry.
What do you think that tumour was?
It's very difficult to know. It's not something you see very often.
No, it's very different to anything I've ever seen before. It was full of blood. It was fed by vessels coming from around the kidney. The pathologist will have to tell us what it is. So we just got to close the abdomen now.
Where is he? Where? There he is!
Hello. Hi, Sylvia.
Dr.
How are you?
Phil.
Hello, good morning. How are you? You well?
Hello.
You well?
Hello.
Hello.
How are you?
How are you?
I'm very well. How are you?
Good.
You excited? Francis, usually with children's anaesthetics, we get you to come through to the anaesthetic bay.
Yeah.
And they will put just some gas for Sylvia to breathe.
Yes.
And Sylvia will get sleepy with the gas.
Yeah.
And then once she's a bit sleepy, we can put a proper anaesthetic in. And at that point, we'll get you to say goodbye to Sylvia.
Yes.
And let us look after her for a few hours.
Yes.
And then she'll be brought back out again, and you'll meet her afterwards.
That's good.
Okay.
Yeah.
It's finally going to happen, Lisa.
Yes, it is.
It's been a long journey.
It's been, yep. Well, Sylvia, see you later. See you, Lisa. Okay. I'm not going to hug you very hard. Okay. All right, I will. Okay.
All right, buddy, let's go.
Okay.
Say goodbye.
All right, love you, Dad. Okay, thank you.
What we're doing now